Hi, it's Dr. Centeno. Sorry about last Friday. We had a little problem. I was moving homes from one place to another, and I was working from home and just having some internet issues there. But I think now we've mostly got it worked out. We're still not 100% up and running in the new place. But long story short, thanks for joining us today. We're going to be focusing on the topic I was supposed to do Friday, which is the concept of IV stem cells treating or curing ligament issues. And we'll choose here craniocervical instability as our ligament issue. So as usual, I'll do a short presentation. And then after the short presentation, you can ask or answer any question you want. I'm happy to answer anything, whether it's about the presentation or something else. So again, today, about IV stem cells and the concept of IV stem cells treating ligament issues. So let me go ahead here and share my screen. Hopefully all of this is working as advertised. And if not, I'm sure I'll get a text here. Okay, so let's share the screen. Looks like that's working, and we'll go to the presentation. So the presentation today is, does a stem cell IV work to treat CCI or really any ligament issue, not only craniocervical instability? Recently on a Facebook group, I read about a patient heading to Mexico to get an IV stem cell treatment to treat their craniocervical instability. There are a couple of different Mexican clinics, but not only Mexico, we see these clinics in Panama, Colombia, etc. And the general concept there is they almost all include an IV stem cell treatment. The issue that all of them have is none of them really have the expertise at a high level to inject the spine at even what we would call a moderately advanced level. So they kind of throw in the IV stem cell as if it's some sort of benefit. So is it a benefit? Is it not a benefit? What's going on with all of that? I've also seen other patients try the same thing here in the US. We see acupuncture clinics, naturopathic clinics, clinics run by physician's assistants or nurse practitioners that use what's called IV Wharton's jelly. They claim this is a stem cell treatment. And again, the concept here is that somehow these IV stem cells are going to go and repair ligament damage. So the big question is, could this work? Is there some way that this could work? So let's zoom out a little bit to what I call the 30,000-foot view. And if you watch this show and this Facebook and YouTube channel, you know that we've got three different types of treatment out there. We'll call it specificity. So we've got the eagle eye with a sniper scope, right? That's the very specific image-guided treatment of placing cells exactly where they need to go. That's why we talk about CCI typing, right? We've got to determine a type, meaning which ligament is involved, to know which ligament to target. It's a very simple concept, but one that clinics generally don't use because they either use what I call the blind man with a shotgun approach, meaning no image guidance and just generally stick the needle in the general vicinity of where it could be supposed to go, or what I call the blind man with a water pistol, which I'm going to really is my name for this IV stem cell treatment, meaning that there's a reason why I'm calling it the blind man with the water pistol, and you'll see. So the basic concept of the blind man with the water pistol or IV stem cell treatment for CCI or any specific ligament injury is that the cells will go to the sites of injury. And this is based on some animal research, but the animal research really isn't a lot like what these clinics are trying to get to happen. So is this true that if you inject stem cells IV, they will somehow magically end up where they're supposed to go in your body? And the answer is a lot more nuanced. The real answer, meaning the real scientific answer. Yes, mesenchymal stem cells can home short distances to sites of acute injury. So if we place them close to the right spot, we will see some of them migrate into the area where they're supposed to go. But that's only if we have an acute injury, not if we have a chronic injury, meaning that all of the different types of studies that have been done on this are experimental models where an injury is created surgically at a specific place. And that's very different than a chronic injury. A chronic injury has chronic inflammation. And an acute injury has acute inflammation. They're very, very different things. They both share the term inflammation, but they're different. So cells can home to sites of acute injury short distances, but they're not going to home to these areas of chronic injury, which is really what we're talking about when we talk about CCI, or we talk about chronically lax ligaments in EDS patients, etc. In addition, we know that mesenchymal stem cells have a first pass effect in the lungs, the same way that medications have a first pass effect in the liver. So 97% of MSCs given IV will end up in the lung tissue and not in the general circulation. The other problem is really just practical, and that's blood supply. So we know that very, very few MSCs after IV treatment will be left to even get into a damaged ligament, only about 3%, because 97% are going to get trapped in the lungs. And then that means that in order to get to the damaged ligament, the remaining 3%, that ligament has to have a good blood supply. And the problem is that ligaments often don't heal because that blood supply got disrupted or is poor. So we have this problem, right? Only a tiny percentage of cells are going to get past the lungs. And then we have to have a good blood supply to the area in order to get the cells there. But in many of these situations, the ligaments don't have a good blood supply. So there's no way for the cells to get where they need to go. And you can see here with the red being blood vessels that ligaments have a problem, right? They tend to draw their blood supply from either end. So let me see if I can get a pen here to mark this up, because y'all know I love to draw. So on either end of a ligament, we tend to see good blood supply. So on this end here, on this end here. But then we get into this middle zone where the ligaments normally tear, or where they've got micro tears, where there is no blood supply. And that's another problem of the way ligaments are put together. And then finally, one of the things I have to mention is that we know that Wharton's jelly preps used in the United States don't contain living and functional stem cells, just dead and dying cells that are non-functional. So that's a critical thing to understand. You can go ex-US and try to get living umbilical cord stem cells. But the biggest problem there, as we've talked about, is going to be a natural killer rejection response. That's a whole other topic we could spend an entire half hour discussing. And we also have the secondary problem of the fact that, as we just talked about, those cells aren't going to get where they need to go unless you've got the expertise to place them there. And ex-US clinics don't have that expertise. So in conclusion, there's little scientific support for the idea that stem cells given IV will end up in the CCJ ligaments. There's zero clinical support that this would work to heal those ligaments. And this is really more of a business plan than a medical treatment. I've got a little typo there, apologize. And the reason why I call it a business plan is that if you look at the kind of doctors, the few doctors who would have the expertise to place these cells where they're supposed to go, clinics aren't going to be able to afford those doctors. So what do? They create this concept that if they hire someone who they can pay 5% of that doctor's salary to, something like a medical assistant, to start an IV, that's the equivalent. Obviously, it's not. It's more of a business plan than it is anything else. So thanks for watching. Let me start to take some questions here to see what we've got there. And I'll get back here. Looks like we got a bunch of questions. Can collagen help with ligament healing or CCI? Yeah, that's a good question. I don't think we have any data or research on this at this point. I mean, clinical data. I don't think it could hurt. So listen, if you can get an inexpensive collagen supplement and you want to take it, I think that's fine. We don't have clinical data that shows that this will help your ligament healing, but I also think it's not going to hurt. E, do you have any recommendations for where to get DMX done in Chicago? Carla would be the person to reach out on that. I know that Caring Medical used to have a DMX in Chicago. I don't know that they still do because I think that operation mostly moved to Florida. So I'll put Carla's email here, and you can reach out to Carla to see if she's got someplace on her list that has a DMX. So I'm just putting Carla's email in the comments. Hello, can collagen help with spine healing, herniated disc, CCI? I think I just answered that one. Same answer as before. Chris, can neck intradiscal injections, PRP, stem cells, ozone, potentially cause a decrease in disc height? If that were to happen, what would be consequence to the overall health stability of the neck? It's possible. Listen, the biggest concern about any injection intradiscal is always starting an infection, which can destroy the disc. There's a 1 in 200 to 1 in 500 chance or so that that's going to happen. It's the reason why we try to stay out of discs unless we really need to go into discs from a treatment standpoint. So the bottom line is, if that were to happen, the answer is yes. Now, could these things cause the disc to get worse? I think is what you're asking here. And in general, we've not seen that with PRP and stem cells, but it's always possible, right? It's always possible that there's a normal degenerative process that gets slightly worse as a result of a treatment. I mean, there's nothing to say that a treatment will work and stop the normal degenerative process. Ozone, it's a good question. I don't think anyone knows the answer to that. And I certainly don't use ozone here in the United States. It's illegal to use in the United States. That doesn't mean there's a lot of people that aren't doing it. There are. It just means that it's not something we're permitted to use here. Karen, when you do PICL, do you inject all the ligaments relevant to C0 through C2 stability, or only particular ones in a particular patient? Karen, a lot depends on the type of CCI. If you've watched this before, we're very, very specific on what we inject. Now, that may mean that we inject lots of different areas in a patient, and we concentrate on certain other ones based on that CCI typing. But CCI typing leads to the specific targets that we want to hit. So for example, if someone has a type 3A instability, C2-3 instability inflection, there's no reason to even do a PICL. We can hit that all day long and twice on Sunday with only posterior ligaments. If someone has a type 2B, while we will hit the posterior ligaments, we also need to hit the alar ligament. So that's a PICL. So that's an example of that kind of thinking. And if you're not getting that type done, then that's a problem, right? Because in order to know what we need to inject, we need to know what's involved first. Specific diagnosis leads to specific treatment. Regenix, Smith advanced by Amber Smith. Higher Centeno, what causes the occiput to continuously move out of place? Mine is out of place every week when I see an AO, along with the first ribs, T3 and 5, and pelvis. Amber, look up those type 1 instabilities. I think I have a couple lectures on that. So if you go back in the Facebook Live, you can see those type 1s. That's where the occiput is unstable. So those are the ones you're going to want to look at, and that'll talk about specific ligaments that are involved in all of those type 1 CCI instabilities. Carrie, higher Centeno, how do you determine the ideal time frame for second PICL? I know the general guidelines, but wondering about fine-tuning for each person. I'm 55 and about 6.5 months out from the first, making slow gains since 4 to 5 months. Yeah, Carrie, I think if you're making slow gains at the 4 to 5 month range, you could push it out further. Certainly 6 months sounds appropriate to me as far as getting the second one. Now, we've got other patients who make much more gains much more quickly, and that could be based on age, injury type, injury severity, levels of systemic inflammation, etc. And they could obviously go quicker than that. It's been advanced by John Gardner. Hi, doctor. Was recently diagnosed with the bulging discs at 5'6" and 6'7", as well as having military neck. What if that's causing tightness and feeling almost loss of blood flow to the head when bending over? Is one related to another? Can you point to the IJV on your neck to see if it is in the same area? No, John, IJV is deep in here, and normally those discs do not have much to do with the IJV. Now, a military neck means that you don't have a normal curve or you've got a straight neck. And if you've got a straight neck, just realize that you're going to be putting more pressure on those discs. So the first thing I would do is to work on getting the curve back, which will take pressure off those discs. But the kind of thing you're talking about isn't normally associated with 5'6" and 6'7" disc bulges. So possibilities could be it's not related to your neck at all, or if it's related to the neck or the upper. Karen, an AO chiropractor said to me that they weren't concerned that PICL might cause the relevant joint, or that they were concerned the PICL may cause the relevant joints ligaments to come too tight, that a certain amount of movement in the area is needed. Wondered how you might respond to this common concern. Yeah, Karen, we've never seen that issue at all. If anything, I think we've seen the opposite, where we can't get someone tight enough because their injury is too severe. So I think that chiropractor just hasn't learned enough about what regenerative medicine can do and can't do. I think the biggest concern, obviously, is fusion, where it becomes way, way too tight, i.e. not moving. But that's generally not something that we've seen happen clinically in doing this procedure now about 1,000 times. Brian, does decrease in bulge of less than 25% at 6 months post-traditional culture hypoxia predict poor outcome per our paper? If stem cells are going to heal an annular tear or reduce the bulge, would you expect to see MRI changes by 6 months? Yes, we would expect to see them by 6 months, but you'll have to give me more information. So if we're seeing a decrease in disc bulge size by about 25%, that's pretty reasonable per that paper that we reported, and we would expect to see that by about 6 months, yes. AT, I've had a bad TBI with post-concussion syndrome. I'm getting upper cervical care and my adjustments are holding. Is there an indication I would not need regen medicine because I'm holding? Yeah, so if you're holding well, you may not need us at all. You may want to move on to the next phase, which would be strengthened. Because remember, stability is half muscles and it is half ligaments. So if the ligament portion is holding, then you want to really go to the next stage of strengthening and see if you can tolerate that. And if you can, you may not need us at all, which is obviously the best of all worlds, right? We all want to be able to take care of this stuff using conservative care and not move on to anything more invasive, including injection-based care, if conservative care will get it done. Genetics been advanced by Harry Winston. Would there be any value in getting my lower neck treated with algo cells in London before going through the process to see if I'd be approved for a PICL procedure? Harry, if you've got lower neck issues, algo cells treats that. They're experts at it, so I would definitely get that evaluated by them. And then obviously, if the conclusion is you still got upper cervical issues, we're happy to see you. John, hi, Dr. Centeno. My MRI revealed a disc bulge, 5667. I got this one already. I think all of that. Got that. Karen, I have a congenital non-union of the posterior arch of the atlas and therefore enlarged anterior arch. This creating problems due to the PICL. Not in particular, but we always like to get an MRI of the ligaments, a 3 Tesla closed bore MRI, looking at the ligament structure in patients who have congenital abnormalities of the upper cervical spine, just to make sure that the ligaments are where they're supposed to be. So that's something we should get before you get in for treatment. So if you've got treatment planned, that's something we can get here, maybe just come a little earlier so we can get that scheduled here. Or obviously, if you don't, we can get that done where you are. We'll just send them the protocol for how that should be done. Genetics been advanced by DB. Is there any evidence that vagus nerve issues can cause anxiety inflammation issues, or is that just a rumor? Evidence. Well, I think right now it's a theory, meaning do we have a lot of hard clinical evidence that vagus nerve issues cause anxiety, inflammation? Some. The most interesting research is actually being put forth by the device companies, which are studying devices to stimulate the vagus nerve internally. These would be implantable devices in order to treat things like rheumatoid arthritis, i.e. stimulating an anti-inflammatory response. So I think the research is mounting certainly on inflammation. I think it's a little bit less solid at the moment on anxiety. Having said that, we certainly see a lot of patients who we believe have anxiety and inflammation related to vagus nerve, and that's just a clinical diagnosis. Carrie, how do you determine the ideal time frame for second PICL? I think I got that one already. John, why does neck pain SCM always come back after a run or overhead lifting, even if just jogging and light lifting? I assume it's the C5-6 discs. Will I be able to run again? If so, typically how long after PRP? John, I'd have to see you clinically to get a good sense of what's happening with regard to running in this area. One of the things we do know is if you've got disc bulges, the small muscles at those sites that are supposed to stabilize actively with things like running are probably offline and not working. That's probably leading to some of these other muscles like sternocleidomastoid to jump in and take over. So we'll see tightness in the sternocleidomastoids, tightness in the upper trap, etc. So that's certainly possible that could be happening. As far as have people gone back to running after getting that area treated with PRP, and I mean really treated, not sort of the fake treatment that you can get some places, but specific treatment. Yes, we've seen that for sure. A lot will depend on how severe those discs are and whether or not there's other concomitant problems. Ace the Assassin, currently an active duty soldier in graduate school studying medical physiology, working towards medical school. This field of study is my interest, along with PM&R and sports med. Can you offer any advice, guidance, and mentorship? Sure. We run a fellowship program. It's selective, but the focus would be taking a physician on average who has completed a PM&R residency. They've gained some basic X-ray guided injection skills in the spine, basic ultrasound guided injection skills in peripheral joints. And then we take that physician for a year and educate them on how to do this stuff. So that's the kind of thing I think I'd recommend if you want to head this direction. Stacy, will spinal decompression therapy between C5 and 6 is shrinking, or space is shrinking, interfere with the benefits of a PICL? Yeah, the biggest concern I would have there is that if you're going to have axial traction this way, it's going to put bad kinds of pressure on the upper cervical ligaments. So I don't think that kind of cervical decompression and PICL are compatible. I think you've got to get those ligaments healed before you could tolerate that. Chris, I have a sensation on my neck vertebrae moving, grunting, clicking, clunking when I swallow. Am I crazy? Is it even possible cervical instability damage neck ligaments? No, it's possible. Yeah, we've seen it before. Just realize that the upper cervical bones and ligament structures are not that deep past the back of your throat, only about 1 centimeter of tissue there. And then you've got bones. So if you've got a lot of instability in the upper cervical spine, that swallowing reflex is enough to move things around to feel that. So that may be very real. Lorlinda, Centeno, have been diagnosed with CCI. I was told my skull does not sit properly on my C1. I mailed out new patient paperwork, including my recent imaging, but I have not heard back yet. Lorlinda, if you could reach out to Carla directly, that's Carla's information there, and she can try to help get you on the schedule for a telemedicine visit. Telemedicine visit is where we go through all that stuff and try to see if you're a candidate for what it is we do. John, I feel I also have a dorsal scapular nerve entrapment. I'm wondering if it's related to the bulge at 5-6. You can treat the nerve that's entrapped with PRP, as well as the root at C5-6. The PRP and airpogenics got me back to 7% healed, but we only hit the 5-6-6-7, not the nerve entrapment, which is causing constant dull pain. Yes, the dorsal scapular nerve can be treated at the same time. John, last question, is PCS treated with PRP as well, and what discs typically are treated to help with that? PCS stands for a lot of things. You're going to have to help me out there. Post-concussive syndrome, maybe, but there's also other PCSs, but that may not be involved. So let me know what you're talking about. Stefan, hello, Centeno. I've had the atlas straightened. I must say that my pain is much less. If I now get a PICL, can the atlas therapy shift with ligaments, then pull the atlas in one direction during the healing process? Listen, Stephen, if you've got good stability with just working on the atlas, then I think you should move to strengthening and see if that'll get you where you need to go. Now, if you're still struggling there to hold that position, that's really where we can help. Our goal is not to pull it out one way or another, but we do see changes in vectors after PICL. So that's one of the things that all AO chiropractors need to be on the lookout for is does someone have new vectors now after PICL? Amity, is it possible for iliac ligament to heal on its own, taking up to 2 years? I mean, it's always possible. Normally, that's not the time frame for ligament healing. Ligament healing happens within that first 3 to 6 months, remodeling fully at around 9 months, depending on your age. Obviously, the time frames are shorter if you're younger. They can be a little longer if you're older, but 2 years would be a lot. What percentage of PICL in our cervical PRP patients are worsened temporarily or permanently? Well, I think we'll have to define that there. So worsened temporarily, meaning a flare-up of 1 to 3 weeks is pretty common. And that's that bell curve that we always talk about. Now, that would be the middle of the bell curve. Then we've got the tails on either end where we've probably got 5% of patients that are worsened in the 6 month plus time frame or 3 to 6 month time frame. So that's generally how that works. So about 1 in 20 if we're using the same terminology. Juanita, are we taking insurance? We certainly take insurance for things like office visits, getting MRIs, etc. Orthobiologics aren't covered by insurance, other than if you're part of the Regenexx corporate program. We've got about 1,000 U.S. insurers that do cover this stuff. I'm sorry, not insurers, but employers that do cover this stuff, but your employer would have to be on that specific list. Brian, your post-procedure rehab guidelines for lumbar arterial state, no lifting greater than 5 pounds during phase 1, phase 2. Just want to confirm this is not a misprint. Yeah, Brian, I think the goal there is just trying to say don't lift a lot. As far as could you run into problems, I think always a better metric is to use those guidelines as just vague guideposts. But you also have to listen to your body. So for instance, if by week 4 you were feeling great, then you might add a little bit more in a controlled setting, meaning, maybe doing some light 10-pound weights in the upper extremity in a controlled core controlled setting, meaning you're controlling your core. So I think they're meant to be more rough guidelines than anything. Chris, can intradiscal or epidural PRP restore lost disc height? Not in general. So if you're seeing people advertise that, that's a scam, and it means that the person really doesn't know what they're talking about. I was the first person on earth to inject stem cells into a disc back in 2005, 2006. So I've got more experience with that at this point than any other living human. And the answer is no. Now, have we seen some improvements in disc hydration? We have, on a case-by-case basis. But as far as a routine patient getting back lost disc height, doesn't happen. Post-concussion syndrome. Yeah, there'd be no area to treat that would treat true post-concussive syndrome. Now, sometimes those sorts of symptoms, cognitive symptoms, are caused by the upper neck. And in that case, obviously treating the upper neck is the issue. So a lot just depends on what's causing what we're discussing. Chris, can an intradiscal injection cause an already unstable spine to be more unstable? Not in general, unless, of course, there was some sort of complication. Have any of the PICL patients ever gotten paralyzed? No PICL patients ever gotten paralyzed. Brian, your post-procedure rehab guidelines. I think, Brian, I've already answered that one. Hold on a second here, guys. I need to take a 2-second break here. Hold on a quick sec. Sorry, I don't have a desk set up here, so this is not too comfortable. New place, no desk set up yet. Can patients with TMJ dysfunction find relief for their CCI despite ongoing TMJ issues? It's pretty frequent that we see CCI patients with TMJ and vice versa. So we'll often treat TMJ at the same time. I think on the Regenix blog, you'll find a case that talks about a woman who had TMJ and pretty significant CCI. Paul, can CCI affect the trachea? I feel a little bit of bony movement and clicking below my Adam's apple sometimes. Not sure if it's what's really moving. Yeah, it's certainly possible, or it's also possible that the same trauma that caused CCI may have injured some of the anterior fascial planes, which control tracheal motion. So we would need to look at both of those, meaning that would be an anterior ultrasound looking at whether or not the trachea is moving and whether or not some of the fascial planes in here may have been injured. It's been advanced by Madeline. How long should it take for an ACL with a small tear to heal on its own? I would give, again, ligament healing if you're young is sort of 3 to 4 months. If you're older, it might take as much as 6 or more. But you're certainly going to want to give it a couple of months. And the big issue there is whether or not you can be active. So if you can be active while it's healing, I think that's a net positive. You may want to wear an ACL brace, though, while you're active, just to stabilize the area and protect the area. Maya, what are the symptoms of TMJ dysfunction? Pain in the jaw, temporal headaches, problems with chewing, eating, all of that good stuff. John, sensations of when you take a mouthful of pop rocks in my neck, low crackling sounds, and that could be. John, that one I'd have to look at more closely. That's not a common one we hear of, so I'd have to look at that more closely. Okay, so I think we're starting to run out of questions. We'll see if more questions come in as I start to wrap this up today. So what we're talking about today is, can an IV stem cell injection do much for ligament? The answer is probably not, but we generally do see that claim, so I wanted to just get into that today. Maya, can CCI affect the esophagus? Yes, in that again, there's only about 1 centimeter of tissue at the back of the throat that separates the back of the throat from the upper cervical spine. So we do see CCI patients that have, for instance, swallowing disorders. Chris, can CCI AAI cause numbness and decreased sensation in the hands and feet? We've certainly seen that, yes. Now, we also look for other causes of that, things like cervical stenosis, cervical disc bulges, etc. But it's certainly possible. We've seen patients with no evidence that they should have that, and then we've treated their CCI and their numbness in their hands and feet have gone away. Okay, guys, well, we are still in the process of moving here. So trying to get desks set up, trying to get the internet good and stable, et cetera, et cetera. So I'm going to start to wind this up, take my last few questions here. Regenics is advanced by DB. Can patients with MCAs get the PICL procedure? You're going to have to define what you mean by MCA. Are you talking about the middle cerebellar artery or something else? Maybe that was supposed to be MCAS. I'm not quite sure. Stefan, can you write them here on Facebook, or should I send a message to Carla? Let's see, Stefan. Let me go back and see what you were talking about. Yeah, Stefan, I think what I was talking about is changes in vectors, not something that I would be able to write. That would be specific to the patient. So we have seen patients who get changes in their adjustment vectors, meaning the direction that the chiropractor is adjusting once the ligaments are starting to heal. Maya, did your herniated discs ever heal? You know, they do, Maya. If we look at studies on herniated discs, about 80% of them after a year are smaller or have gone away. So the body does get rid of them for the most part. Amber, what causes an occiput to constantly slip? I think I got that already. My occiput slips weakly, causing balance issues, brain fog, and so on. My atlas is staying in place after rear prolotherapy. It could also move too much if I lift. Yeah, so I think there what we're talking about are very specific ligaments. I've lectured, I have a couple lectures, so that's the type 1 instabilities, type 1A, type 1B, type 1C, type 1D. So for example, type 1C is a sliding type instability that could only really be treated through something like PICL. Type 1D would be rotational type C0, C1 instability. You could get that with a 0-1 facet capsule from the back, and you'd need to get the facet capsule and the LAOL ligament from the front through a PICL. So those are some examples. Yeah, I agree. I have questions. If I have questions to them, I mean, can I write here on Facebook? So I know that Sure, Stefan. Yeah. Can AI or overhangs get worse with time? I don't know that we've seen it be progressive, just not get any better without treatment. Stefan, 5 questions. Yep, I got that. Thank you very much for all the answers. Sure. So Stefan, yeah, listen, I mean, I think you have my email, so just go ahead and drop me a line directly, and I'll try to answer your questions as best I can. Okay, guys, thanks so much for watching today. I'm going to cut it a little bit short just because I got a lot of moving parts, a lot of balls in the air trying to move from one place to another. So I want to focus on that a little bit, but thank you so much for watching. I did want to get out there and finally get this done. Sorry for all my internet issues here. I think we've got it somewhat stable now, but we're going to have to get a better internet system in this new place. So thanks so much for watching, and have a great day. I will be here this coming Friday where we'll have another topic to talk about and another Q&A. So thanks so much. Thank you.